I have a call I'm going to be on, but I have to record it, the audio. So it's going to be on over here.
So you don't need noise in the background.
Yeah, noise in the background. Maybe. Well, no, it's recording from my
Okay.
PC, so you can
Okay.
talk and it's not going to pick it up.
But there'll be some noise I'll be hearing. I got you.
Yeah, I use a program that records what's going on the laptop, not ambient. I did that on purpose because of all the things I have to record.
Is she live? You're live, Treasure.
Good morning, everyone. This is State Treasurer Dale Falwell. Thank you all for joining us for our Ask Me Anything call. You all received a press release regarding some of the issues that we're going to talk about today. If you wouldn't mind muting your phone if you're not speaking, that'd be great. And with that, we have a lot of important topics. Just very briefly, as per law, we just got our stress test done on the state pension plan. It shows that for the first time in a long time, we have a 75% chance of hitting our assumed rate of return over the long-term horizon. Obviously, with the financial pressure that stocks have faced over the last several days, it's just another indication of the fact that we are managing one of the largest pools of public money in the world, but it's a mature plan. For those of you who have 529 plans, just think about what you did for the first 17 years of putting money in a 529 plan versus what you have to do as your child starts going on to higher education. The stress test is important, and I just suggest that when you look at it, that you understand that it's a stress test. Like if you went to the heart doctor and got put on a treadmill, it's meant to show the most pessimistic outcomes going forward. So when you see 2% or 3%, that is not what we're earning. That's what the stress testers put the plan under to see if it had that had a good shot of remaining viable. The other thing I covered in the Council of State meeting this morning is a letter that we sent to the federal government regarding GLP-1 drugs and formularies and other types of things that go on there. I'm sure we're going to get a few questions about that. We are still under siege of state health plan. The General Assembly, we have asked and not received for a number of years, hundreds of millions of dollars of COVID-related expenses that we've actually paid out for COVID. The plan is going to go below its thresholds for reserves. In addition to that, the unfunded liability continues to go up. So this is not a crisis that's going away. And ultimately, it's going to impact those that teach, protect, and serve. And that's why we look forward to a real honest, open, mathematical conversation about where the state health plan is going forward. With that, I'll be glad to take questions anybody might have. If you'll raise your hand. No, that person. AP Dillon.
Good morning, Treasurer. Thank you for taking my question. So you're saying that the unfunded liability for the state health plan is continuing to go up. Can you give us a little bit of figures behind that? What are we looking at in terms of the gap?
I'm going to do this from memory. During the last 7 years, AP, I'm as a member of that committee, what they call the OPEB committee, I have resisted changing too many variables in that report because, as you can imagine, with a $30 billion unfunded healthcare liability, that if you start to change one thing just slightly, it makes the unfunded liability swing wildly. But in addition to that, one of the biggest components of figuring that unfunded liability, the two biggest components. One is that even though we have money in the unfunded liability, it's only about 9% funded now. It was 2% funded when I came on board. A part of how it's calculated is based on what the 10-year municipal bond rate is that's posted in the Wall Street Journal on the last day of the fiscal year. So it's approaching near $30 billion. Again, we'll give you the exact report. The OPEB committee has met, but the final report's not out. But it's very clear to see that if interest rates continue to go up, which they are, if healthcare costs continue to go up, if prescription drug costs continue to go up, and the amount of money that we continue to get from the General Assembly is not keeping pace with that inflation, nor are we being reimbursed for actual expenses for things like COVID-related activities, you can see that's going to be an issue. Everything else going on with the state's balance sheet is in great shape, except for the DOT debt and DOT budget. But this is something that we continue to monitor. The rating agencies monitor it also. And as I said earlier, we look forward to having an open, meaningful, mathematical conversation about the state health plan and these unfunded liabilities. Follow up?
Yeah, in terms of the COVID money that's due to you, can you give us sort of a rough figure of what that is?
It's my understanding that we have received less than half of the $500 million of COVID-related expenses. So we're looking for another $250 million. This is money that the General Assembly in the state of North Carolina has received from the federal government for COVID-related expenses, and we spent that money for COVID-related expenses. And so we're looking at well over $250 million. Rose? Oh, AP, you have a follow-up?
Nope, I'm good, thanks.
Thank you. Rose? Rose, you still there?
Sorry about that. Thank you. Good morning, Treasurer. Thanks for taking my question. Your press release yesterday stated that the state health plan is on the brink of insolvency. What does that actually mean? You say we've got $100 million or $106 million loss. you know, does this mean that the plan is going to collapse? Are you looking for money from the legislature? Are we in the kind of position that we were in 2009? Could you elaborate a little bit more?
Yeah. The trajectory, by the way, a lot of this trajectory was in the oven before I got here. Number one, and it's something many people on this call know that I've been talking about for at least 19 years. What's made it worse now is that prescription and health costs are going up at a at least twice a higher rate than the amount of funding that the General Assembly has chosen to give us. Number two, the General Assembly has also not chosen to reimburse us for actual COVID-related expenses. And the plan can only pay its bills based on the premiums we receive and the appropriations that we receive from the General Assembly. That's the biggest portion of where we get our revenue. We have done everything humanly possible to cut administrative expense, to cut all types of expenses out of the state health plan. So what it will mean is that the General Assembly will have to put more money in the plan like they've had to do in times in the past. But it's also important that they understand what we've been trying to do. We set out 7 years ago to have reference-based pricing. The General Assembly could have passed reference-based pricing. That would save $300 million a year. We would not be talking about this today, Rose, if that would have occurred. Secondly, the cost of health care has continued to go up at twice the pace that they've reimbursed us. Thirdly, I'm the first treasurer, I think, in state history to ever put an individual premium on the state health plan. So for members of the General Assembly who always said, you know, the employee should pay something. Well, I did that. We did that. Our board did that. So it's not like we haven't taken those steps. Another point is that we have cut hundreds of millions of dollars of expenses out of running the state health plan, and we can document all that. Now, where have we made investments? We have made investments in higher reimbursement rates for primary care physicians, physical therapists, mental health specialists, and one other group. My point of saying that is that it's my opinion that primary care physicians, mental health specialists, and physical therapists are the closest to the well-being and the health success of our members. We're only given one body. And those three groups of individuals have the best shot at getting people the care they need and keeping them out of hospitals, which is where the cost goes up dramatically. So my closing by saying, Rose, that the money has to come from somewhere. And especially in this inflationary time, when we have family premiums, we have a lot of average state employees who are having to work 1 week out of every 4 to pay the family premium. 1 week out of every 4 going up on premiums, family premiums for those who are already struggling. I just don't think it's the answer. The answer is to sit down and have an open communication. If somebody thinks that we've done something wrong, if people think that we should not have invested in primary care, mental health, or physical therapy, then they just need to say that. That could be an item of disagreement. But the fact is that when someone goes to the doctor expects to get paid, and our customers expect us to pay their doctor, and that's where we are. On top of that, there is a situation with the Medicare Advantage contract where we thought we were going to be getting into another premium-free year for the state employees. It is going to be premium-free for the state employees, but it's going to cost us tens of millions of dollars that we were not anticipating based on the glitch or something that happened in some piece of federal legislation. And I will tell you that we're going to pursue to make sure that that's something we should be paying. Follow up.
Tell me a little bit about the plan. Has the state health plan invested in value-based care, or is it still primarily a fee-for-service plan?
It's primarily a fee-for-service plan. In 2017, thereabouts, I was presented as we were attempting to say, we predicted this 7 years ago. And we set out a goal to save, in order to keep the plan solvent, to save $300 million a year. We put forth a plan to do that. The head of the hospital association sat in this this chair right here, and said, well, you're not our customer. We really don't even have to talk to you. And I said, what do you mean by that? He said, you can't find a contract in this building with our hospitals. Our contracts are with Blue Cross Blue Shield, not with you. That is technically accurate. But the reason that I'm saying all that is that we set out to save $300 million. I still have the board book, but we were presented with a value-based alternative from Blue Cross Blue Shield. And if my memory's right, it saved like $20 million a year, not $300 million. And when I started asking the tough questions about how do you actually, this whole profit sharing and cost sharing, it all sounds fantastic, but how do you operationalize it? And at the end of the day, what I was told repeatedly is that this will not cause the expenses of the state health plan to decrease. It will only change the trajectory of the increase. We need to lower healthcare prices in this state, which will make healthcare more accessible. And there's an easy 5-step plan to do that.
Is the, based on the language in your press release yesterday, is the plan in danger of imminent insolvency, or you're talking about long-term insolvency?
Yeah, we will go below our statutory minimums in 2025.
Okay, thank you.
Next. Rose, we're one pandemic away from not being able to pay our bills. Zachary?
Hi, Secretary Falwell. Thank you for taking questions. If this funding gap is rectified, how does that change how the state health plan is operating right now? I mean, would you still be in the mindset of trying to cut costs and eliminate, some of those prices, or would you be able to operate in a different manner if that money does come?
We would continue going down parallel paths to provide high quality, high access, low cost healthcare to public service workers. I think that just freezing the family premium is not enough. I think we actually have to lower the family premium to make a difference. I won't not be here when these statistics are available, but I would, as I've said in the past, Zach, I think there's a high degree of state employees their very own dependents are uninsured because they can't afford the family coverage. They cannot make the choice, even in this, especially in this inflationary time, between healthcare and food, healthcare and heat, healthcare and mortgage, or healthcare and living their life. So it's a serious issue. And I would just add to what you were asking, that this is something that's, we've been talking about for a long period of time. If we got reference-based pricing, which would give the hospitals 100% profit, and we've put out many peer review reports about how this will actually work, they would make 100% profit on the backs of those that teach, protect, and otherwise serve. If we were to get that, and we continue to cut the expenses that we're cutting, and we're looking forward to our partnership with Aetna to cut expenses even more, then we got a shot at keeping the plan solvent. But at the end of the day, as I talked about a moment ago about the pension plan, when I said that the pension plan is mature, that there are less people paying into the plan than are not, you can apply that same calculus to the state health plan. Because there are a lot of people who are vested in the state health plan, no longer working for the state, no longer paying into the system, but yet drawing, but we have expenses associated with them. Follow up, Zach?
Yeah, I know GLP-1s have been something you've mentioned a lot in the past about creating a lot of costs for the plan. I'm curious if there wasn't this gap and if this gap was rectified, I mean, is that something like the state health plan would reconsider, or is that, just more examples of costs that you're not willing to take on?
Well, thanks, Zach. Just some statistics. Americans get charged up to 15 times more for GLP-1s than peers in Canada, Japan, or Europe. It's estimated that these GLP-1 drugs, and here's an example of them right here. It's estimated that the cost of this is less than $75 a month. The retail price in North Carolina can range as high as $1,200 a month for this one drug. Secondly, now that North Carolina Medicaid has made their decision to expand or to cover GLP-1s, I have asked this question repeatedly and have yet to get an answer. How much are you paying for this? And I still do not have an answer from DHHS about what DHHS is paying for GLP-1 drugs. They always want to talk about the physical note about the percentages. I'm pretty good with percentages. I'll do the percentages. Just tell me what you're paying for this. And Zach, what I'm telling you and telling your audience is that if North Carolina Medicaid is paying $200 for this and we can hitchhike with them, we'll find a way to budget it. But we don't know what they're paying for it. And that's all we're after. The other thing that you did not ask about is the letter we sent to Washington, D.C. regarding GLP-1 drugs. There is some precedent for this going on. The federal government has repeatedly used this law, and it's really a law, section 1498, where we're asking the government to contract with generic producers to manufacture the treatment for use by Medicare, Medicaid, and governmental programs like ours regarding GLP-1 drugs. This law that's already on the books gives the U.S. government the authority to make or purchase a patent invention without the patent holder in exchange for reasonable compensation. My point of telling you this is that the Bush administration considered using 1498 to produce the generic versions of antibiotics during the anthrax scare of 2001, which led to the manufacturer cutting the cost. The Louisiana Secretary of State began to explore whether she should request the federal government to use Section 1498 on hepatitis C cures. Leveraging the prospect of licensing 1498, the Secretary negotiated major discounts, and Louisiana recipients received the cure in the next 75 days, and then in the entire physical, received more of the cure in the next 75 days after this was done than the entire physical year before. And my point of saying all this to you, Zach, is that this is not something that we desire to do. Our door and our mind and our heart are still open to any of these manufacturers who are producing these weight loss drugs. And we look forward to working with them and we look forward to the information about what North Carolina Medicaid is paying for this drug. It's a public entity. I can tell you what we were paying, and you can look up what people in other countries are paying. We deserve to know what North Carolina DHHS is paying for this GLP-1 drug. Follow up, Zach?
No, I appreciate it. No other questions for me.
Who's next? Hey, Lynn. Lynn Bonner. Okay. Richard Craver.
Senator Richard.
Richard?
Sorry, can I jump back in?
Of course you can.
Okay, thank you. I was having trouble unmuting. So if I understand this, is it 2026 that the health plan will no longer be able to pay the bills? I'm trying to figure out exactly what insolvency means. Is that what it means? And is that the year?
That's a pretty good estimate, Lynn.
Okay. And if you received the 250 million from the legislature, I'm wondering, does that solve the problem long term? Because it looks like from some of the graphs that I've seen that it really doesn't. It might solve an immediate problem, but looking down the road, there would continue to be shortfalls. Am I right about that or wrong about that?
Great question, Lynn. The General Assembly fully funds the pension plan based on the cost. We need them to fully fund the state health plan based on the cost. Period. And that is the long-term solution. The second long-term solution is to give the state health plan the ability to have reference-based pricing as far as what we're paying for hospitalization and hospital cost. And that reference-based pricing, the last time we tried to negotiate that was nearly 200% of Medicare. And we put out a report 2 years ago that showed that these entities actually make money on Medicare, regardless of what they tell you. So you're exactly right. When we get the money from the General Assembly that they've already gotten to reimburse us for COVID-related expenses, when that occurs, that'll just push the problem out. The longer-term solution is to get reference-based pricing, repeal certificate of need, start matching the charity care. We talk about medical debt. We have a report out from several years ago that showed there's hundreds of millions of dollars of medical debt on North Carolinians that should have never gotten a bill if the Internal Revenue Service, the North Carolina Department of Revenue, and any other regulatory agency that has the responsibility of making sure these nonprofits are matching the billions of dollars of local, state, and federal benefit they get with the charity care they're supposed to be offering. If all that were occurring, people wouldn't have a medical debt. Many people wouldn't have a medical debt situation because they would never gotten a bill to start with. So there's it's not easy, but there's a simple 5-point plan to actually solve this problem long term.
Have you spoken to legislators about indexing state government contributions to medical inflation?
We would love to have that conversation with legislators about doing that.
Thank you.
Richard? Who's next? Hey, Richard. Okay. Next. We'll come back to Richard. Okay.
Are harmful to the SHP patients in office billing versus outpatient billing?
Right. That's a great question, whoever asked it. All right, I'm going to repeat the question. How do I feel about the cartel, the major hospitals in this state buying out some of the smaller hospitals, and then the billing practices that get associated with those large hospitals as it relates to some of these communities? It's not Republican or Democrat, it's immoral, what's happening. And I will say to anyone on this call listening, I defy you, if you are seeking medical attention, once you walk into a facility, for you to report back to me whether it was ambulatory or non-ambulatory, and as it relates to this particular question, whether you're going to get a facility fee or not a facility fee. I've had folks tell me in Winston-Salem that these major hospitals own all these doctor practices and all these places around the triad. And for the exact same procedure, you go here instead of going here because this one doesn't have a facility fee and this one doesn't. This one does. this is the type of thing that's going on as far as medical billing. As I said in the Council of State this morning, no one consumes healthcare in this state, it consumes them. And these multi-billion dollar corporations who disguise themselves as nonprofits have made these billions of dollars on the backs of sick people. And the practice that was mentioned in this chat is, as I said earlier, not Republican or Democrat, is simply immoral. And the 5-point plan is for these hospitals to start abiding by President Biden and President Trump's executive order on transparency. Number 2 is to literally match their charity care, not the retail charity care or some trumped up number or grossed up number on charity care, the actual charity care with the tax benefit they receive. Number 3, stop breaking people's kneecaps for not paying their bill. Number 4, the General Assembly needs to repeal the con on the people of this state with certificate of need. And number 5, these multimillionaire hospital executives need to have the courage to show their contract, their compensation package, which I think will prove that their board of trustees are incenting them to put profits over patients. And as long as the boards of trustees of these entities are not holding these CEOs accountable and always putting profits over patients, it's going to be very difficult to solve this problem. Richard, one last chance.
Yeah, we finally figured out the whole Mike situation here. So in this instance, you're basically 5 months and change away from the end of your term as treasurer. So do you feel freer to discuss these topics that you're talking about, whether the state health plan, whether it's legislative funding? I mean, I can understand it would be a source of frustration given the surplus that the state has right now, that this money's not being directed toward making the state health plan solvent or some other issues involving healthcare or the financial stability of the state.
Richard, it's a source of frustration and it's a source of embarrassment. When I applied for this job, my intent was to try to get family premiums lowered. I think by bringing family premiums down, we could have gotten more young, healthy people to offset people like me and my age. We have not been successful in doing that for lots of different reasons. So as far as the temperature of my remarks, Richard, I don't think that you can tell any difference in what I've been saying about this than what I said about the General Assembly in 2010 and 2008 and 2006. It's a crisis. It's not an emotional, it's not political, it's simply mathematical. And both political parties are responsible for the situation that we find ourselves in.
One follow-up question. Also, by pointing out these issues, do you feel like this may be something that you can kind of help influence who your successor may be in terms of their focus? Because also you saw the op-ed piece in which there was some questioning of your holding of stock investments with the North Carolina Pension Fund, and obviously the last few days has shown, to your point, the ebb and flow of all that with the stock market. So do you feel like that you can kind of help guide your successor, whether it's a Democrat or Republican, on what are the key issues once they take over?
Well, my door and heart and mind are open to whoever the next treasurer is going to be. And Richard, when I talked a moment ago, it's something you're very familiar with, the maturity of a 529 plan. And, the pension plan is a mature plan. There's less people paying into it than are not. The exact same thing that happens with your 529s when your child goes off to higher education. You go in from taking money in and investing it to having to pay it out. The pension plans, we're going to pay out gross $7 billion in benefits this year. $7 billion in gross benefits out of all these plans. That gives you an idea of the enormity of this. On top of that, my door, heart, and mind are open to anyone who's applying for the job to be the next treasurer, and that's true yesterday, it's true today, it's going to be true tomorrow. At the SRP Supplemental Retirement Plan Board meeting, at the State Health Plan Board meeting, at the Local Government Commission today, at the Banking Commission tomorrow. These are all some of the boards that I chair. we have extended opportunities for both people who are running for treasurer to attend these meetings either in person or virtually, because this is a very important role, not because I'm in it, it's just because it is. Uh, So I would look forward to any treasurer candidate or the next treasurer of North Carolina to come in and sit down and have a mathematical conversation about how we got here. The State Employees Association know how we got here because they've been talking about this for a long period of time, and they're at all of our roundtables, they're at all of our public meetings, so they fully understand what's going on. I'll also say that to your point about Governor Martin's editorial that was just submitted to the Charlotte Observer and the Raleigh News Observer, I've had a high degree of respect for Governor Martin and in so many different ways. But something that's been talked about on a couple of occasions is that we have too much money in the mattress. There are no mattresses at the treasurer's office. Everything that we have here is invested, and the amount of money that we have invested in short-term investments has been yielding over 5% this year. So my point is that when you have a mature plan where there are less people paying in the plan than are not paying in the plan, you have to be able, in a financial position, a conservative financial position, to take advantage of buying opportunities when they occur. And that's what we've done in the past, and that's what we're doing currently. Okay. Is that it, Richard? Okay. Rose, you got one follow-up?
Yes, thank you. So, you've been talking about the issue of medical debt for a long time. I'm just curious about your reaction to this new plan that was proposed by DHHS and got approval, what was it, last week from CMS, that would incentivize hospitals to eliminate debt for a lot of patients. What are your thoughts about that?
Well, I don't understand all the nuances of the DHHS strategy, so I'm just going to give it to you in the ways that I think about. Here you have the hospitals who will not tell people what things cost. People don't, when they get their bill, don't know if they have if they've had an appendectomy or a tonsillectomy. Everybody in this state knows there's something wrong with healthcare. Then they send people medical bills. Then they will not match the level of charity care with the billions of dollars of tax benefit they're getting. And now they expect the government to bail them out. That's not my solution. My solution is to lower prices, tell people what things cost, start matching your charity care with the billions of dollars of tax benefit you get, and show your compensation package as a multimillionaire executive. Show your compensation package, which I think will prove that these CEOs and the boards of trustees who enable this are putting profits over patients. That's the answer. Not to be an enabler to the very institutions that have put this medical debt on people. Yeah, that's it. Is that it, Rose?
Yeah, thank you.
Yeah. Anybody else have a question? All right. If not,
I do, Treasurer. This is Chris Robinson, Tribune Papers.
yes, how are you?
Nice to see you again. Let me pull up my question for you, although I probably don't have to look at it. So actually I have a couple if we have time. First of all, I would like to ask you, there are a lot of reports and studies now coming out on people who have had adverse reactions or are permanently disabled, perhaps, from the vaccines. Have we seen, in addition to the inflammation, a huge increase in healthcare costs in North Carolina since 2021 when the vaccines started?
Christine, I think about a lot of different things all the time. And I will say to you and everybody else, that's a rabbit that I have not run. I appreciate you bringing this to our attention. I will query our subject matter experts at the State Health Plan and see what information we may be able to provide to you in the next few months.
And I wonder if you'd even be able to get that information with the way things have been. However, and I, for one, appreciate your service to North Carolina. Thank you very much. And your open door policy. It's been lovely to deal with you. I do have another thought. For most of my life, I was an independent contractor and I didn't have health insurance. There's a lot of people who are in that position at this point in time and can't afford health insurance, even with the Affordable Care Act, which seems to charge different prices for different counties, which makes no sense. To me, that's not equal representation under the law. I know because of my experience that if I offer to pay cash to a doctor, I'm going to get a discount. Sometimes it's a pretty substantial discount. I also discovered when I did go into a position where I had health insurance that what cost me $40 for an office visit to my chiropractor, as it were, if I used my health insurance, would have cost me $125. So we have a huge, I don't even know how to say it. We're paying a lot more for services through insurance companies than we do if we just pay up front. One doctor explained to me that that was because they don't have to pay a full-time employee to file the insurance, but it's also the way the insurance company forces the doctors to charge for services. Can we not do something about this?
Well, let me just say on the issue of medical debt, which other people have asked about, the General Assembly could snap its fingers and catapult North Carolina #2 in the country for protecting consumers on medical debt. There's a bill that passed the Senate 44-0, is sitting in the House. It protects widows. It protects widowers. It keeps people from being charged these astronomical interest rates on these credit cards that these hospitals are making as a profit center by issuing credit cards. That bill is sitting in the House. It could be passed almost immediately. It's number one. So, protecting consumers is something that I'm highly interested in. Number two, I have personal experience in my family of someone who the copay was $85, who had insurance, and the cash price was $70. When I first became the treasurer, and you need to ask them about this story, but it may be one of the reasons that I got the state employees endorsement to be the treasurer in 2016, is when I showed them that our prescription drug plan had a gag order in it. It means exactly what you think it means. It means that a pharmacist was gagged, prevented from telling you that it's cheaper not to use your insurance card to buy that prescription because it was $2.40 versus $10 copay. We've removed the gag orders from our prescription drug plan. My point is that this is like an onion. The more you peel it, the more you cry. But at the end of the day, people are suffering and the system is going to collapse. Many of you know that several months ago, I talked to Senator Bernie Sanders for, close to an hour. And he informed me, for example, this is for Zach, for the GLP-1 drugs, that if the federal government were to start to cover these, we're not talking about millions, tens of millions, billions. We're talking about $3 trillion just for GLP-1s. So everyone knows that something's broken, and my job is to advocate for the invisible. Powerful people do not like it when I don't look the other way. But when I see things that are unfair and unjust regarding ambulatory service centers, regarding facility fees, regarding medical debt practices that end up destroying people's upward mobility and their joy of achievement, I'm going to say something about that. And that's what I've always done, and that's what I'm going to do for the remainder of my term.
And I appreciate that. And you and I have talked about HCA also had a personal experience with my mom who broke her hip
Mhm.
and had to have surgery there. And when the attorney was trying to figure out how much was actually paid to them, they couldn't tell them. It held
Right.
up the lawsuit for years, literally, trying to figure out how much was actually paid. And when it was finally down to a $30,000 discrepancy, the attorney contacted the hospital and said, what is this $30,000 that you're saying you received from Humana, but Humana's saying they didn't pay it. And the next time he went in the portal, it was just gone.
Yeah.
So it looks like HCA kept it and just took it out of the records.
Well, we all know the disaster that's happened in Western North Carolina over the last 5 years with the HCA's takeover of Mission Health, and we all know that. And regardless of how people feel about any particular topic or who they're supporting for president, there's a hell of a lot of people who moved to Asheville, North Carolina, to retire because of the high quality, high access, low cost, and the independence of Mission Health. When you used to go to Doug's Hot Dogs or places I used to go in Western North Carolina and you saw somebody wearing a Mission Health outfit, I mean, that was a sign of pride. They were part
Yes.
of a community. They were part of a family. Now it's just been a complete disaster. And I'm sorry that this has gotten in the political realm. But, you know, there's only one person whose fingerprint is on that transaction. That's the Attorney General of this state. And if you see what's happened in Mission Health and HCA and see what's happening with Novant taking over Cape Fear, New Hanover Regional, sorry, New Hanover Regional, and how that is the combination of a hospital that came together after in the mid 60s. This is happening all across the state. So, well, with that, I want to thank all of you. Before I close, I want you to give me a moment of personal privilege. With all the excitement going on with the Olympics right now, just a couple miles from where we're sitting is where Jim Valvano is buried, and on his headstone it says, "Every day you're supposed to laugh a little, cry a little, and think a little." We've all done that during the Olympics, and as I said, the Council of State today, we all know how we feel when some of these higher profile folks perform the way they perform. But nothing really touches me quite like when an announcer who's used to this all the time, when their voice breaks, when somebody gets a bronze medal or silver medal or gold medal, just great examples of great things that are going on. Or if you haven't seen it, Tim Boyum's interview on Spectrum TV with Tommy Burleson, whose voice broke as he mourned 50 years later for the parents in the massacre in the Olympics that Burleson was going to be a participant in, who lost their sons in that horrific murder in the Olympics 50 years ago. And Tommy Burleson, who's a North Carolina tree farmer, continued to be uncontrollably emotional about that. My reason for saying that is we have our own Olympians here at the Treasurer's Office, and we're in the process of recognizing some of them. And those two groups are the imaging department. We stayed in the check delivery business during COVID, but the people that really stayed in the check delivery business were the imaging department. You can imagine the amount of mail we get in the Treasurer's Office every day. And they were here every day, opening envelopes, opening documents, getting death certificates out, birth certificates, all the things that we deal with at the Treasurer's Office, and also our call center. No one calls our call center to book a cruise. They call because they've had a life-changing event. So as I close today, I just want to honor all of our Olympians and those that are representing our country, but also want to honor the Olympians that we have here in the Treasurer's Office who have kept us in the check delivery and the customer service business. So with that, I look forward to visiting you next month. Have a great day.